We welcome in Dr. Gary Green. He is the medical director for Major League Baseball. Dr. Green, it's Brian Kenny. Thanks for joining us.
Thanks, Brian. Thanks for having me.
Well, Gary, how did the league and medical professionals such as yourself devise this plan to get players back on the field?
Well, this has been an incredibly complicated issue, and it's really required the resources of the commissioner's office, everyone from the commissioner on down who's pitched in on this, as well as our drug testing lab in Utah, as well as the Players Association. And when we broke camp in March, we were given the task of trying to come up with a possible reentry plan when and if we were able to restart. And this has been quite a challenge, as you can imagine, because the situation on the ground has changed dramatically over that time. So at the time when we were trying to come up with a plan, we didn't know how many games we'd be playing. We didn't know where we would be playing. We might have been involved in other venues other than our traditional parks. And we didn't even know if there was going to be a season at that point. But despite that, we pushed ahead, trying to develop the most comprehensive plan that we could find. And that's been quite an effort, as you can imagine. If you think about it, in March and April, we were considering playing in places like Florida, Arizona, Texas, and California because there was an outbreak in New York. And had we decided to do that, you could see that now that would have been quite a problem, given where the virus has gone now. So despite that, we were able to really come up with a very comprehensive plan. And then once the parties finished their negotiations, we had about a week to then implement this plan.
So the plan is, we had spoken briefly earlier, and you didn't want to be using areas where people were still trying to get tests, because that's still an issue across the country. You have your own lab where this testing is being done?
Yeah, we knew that early on that testing would be an issue, especially when we started in March and April. There was a lack of capacity in the United States. And so what we didn't want to do is to take away samples and testing capacity from people who really needed it, people who were sick and in hospitals. So what we did was we took one of our drug testing labs in Salt Lake, the Sports Medicine Research Testing Lab that we call SMIRTLE in Salt Lake. And since there was no drug testing samples to be done at that time, we converted that lab under the direction of Dr. Eichner, who runs that lab. We converted that to a virus testing lab so that we would have, number one, the capacity to do the number of tests that we needed, and number two, not to take away from the capacity of the United States in general.
What kind of testing and how often? What's the protocol?
Well, testing is an important part of this protocol. So the tests so far, we've been doing about 2,000 tests a day. So since we started the intake testing a little over a week ago, we've done over 10,000 tests. So this is a massive enterprise, and this group of individuals that are being tested is probably one of the largest groups that's being tested the most frequently in the United States right now. So in order to be able to get testing done rapidly and accurately, we've had to convert that laboratory in a very quick time, and the laboratory there has done just an excellent job of coming through for us.
Now, you're doing saliva testing, right? What's the difference between saliva testing and the swab testing that we see quite often in the news?
Well, the testing that we're doing, there's two types of testing. First is what we call a direct viral test, so what we call a PCR test. And this can be done on a variety of samples. It can be done on what's called a nasopharyngeal test, where they take a very, very long Q-tip and put it fairly up into your nose. I've had that done a few times. It's not a very pleasant experience. And then they can do a test, just the swab of the inside of the nose, the back of the throat, or saliva. And we've had our lab check these and verify them against each other. And we came up with the saliva test to use so that it's easy to collect. There's a lot of volume of material, and we can do them repeatedly. So we've done the saliva test. And that's different than some people might do what's called a swab test, where they take it, put it into a point of care machine that they have in their office, and gives you a result in a few minutes. There's been some concern of the accuracy of those. So we've decided to do the PCR test, which is the gold standard for a virus test at this point.
And could you test negative with the swab and positive with the saliva test? Is it just a little more complete?
Yeah, the PCR test that we're doing is more complete. And we have had cases where the swab test or the point of care test is not performed very well. And we wanted to make sure we had the most up-to-date testing. And kind of a way to think about that PCR test is, if you had a pair of headphones on and you were listening for a particular sound, and if you couldn't hear it initially, you kept turning the volume up until you eventually heard the sound. And that's kind of an amplification process. So what you're doing is you're amplifying the genetic material of the virus until you can detect it reliably. And this test tells you whether you have the virus right now if you're infected, versus an antibody test, which we do through either a finger prick or a blood test. And that tells you whether you've developed antibodies to the virus. So that can tell you whether you've been exposed in the past and if you've made antibodies to that virus particles.
Are you doing antibody testing then?
We are. We did antibody testing on everybody on intake, and then we're going to be doing it periodically through the season, as well as testing people who have already tested positive to see if they've mounted an antibody response to the virus.
So explain that. How often does that happen? You have intake testing, and then is it maintenance testing? Is that what it's called? Like how often is a player getting tested?
Yeah, we would call that surveillance testing. So following the intake, we've then started surveillance testing, and the players are tested every other day. And so we've done about 6,000 maintenance tests, surveillance tests since we did our intake testing, and we've had a very low amount of positives, under a 0.5% or so. Which, again, what I would say was the testing. While testing is certainly important, it's only one part of the procedure. So I would consider testing as the icing on the cake. It's kind of your final exam to see if all the other procedures that we put in place, which includes symptom checks before they get to the ballpark, particular attention to hygiene and sanitation in the ballpark, social distancing, use of masks, and cleaning, and then what they do after they leave the ballpark. So avoiding places that would be at high risk, that would put the players at risk. And we developed a very extensive education program for the players that they've all had to watch, that outlines what they have to do to stay safe, to protect themselves, their families, as well as their teammates. And really, the whole league depends on the ability of each individual player to follow these guidelines.
Dr. Green, it's obviously a huge enterprise. Most teams have had everything go smoothly, but a few teams have had workouts pushed back waiting on test results. What happened there, and how can that be avoided moving forward?
We had a big challenge initially because we had to do everybody's intake exam in order to let them enter the ballpark. And what happened is teams started also reporting a little bit early, and then we started having to do the surveillance testing. So we were caught in the middle of having to do intake testing and then also do the surveillance testing. And unfortunately, we also had the July 4th weekend, which delayed some of the samples being shipped. So we've overcome that now. Almost all of the samples now, if they're received the next morning, they're done by the end of that day. So I think now that we're doing about 2,000 tests a day, I think we're going to be in a much better position for that. And in addition, the teams can continue to play waiting for those results, and we're trying to get them as quickly as possible. Obviously, if somebody has symptoms, we're going to take them out of circulation and make sure they get tested at the local level more rapidly.
Just quickly, given that you imagine you have an awful lot of data on this and you have a big group and it's going to be continually tested, do you expect to find something here that would be for the greater good?
Yeah, I think that from the beginning, Major League Baseball has tried to make sure that we're contributing to the community. As you may remember, in April, we participated with USC and Stanford in a surveillance program for antibodies that also took into account about 5,000 MLB employees around the country. And that was very important data at the beginning of this epidemic. As I said, this is going to be one of the largest cohorts of people that are tested really frequently, and we're going to have a lot of data in a very short period of time. We're going to have not only tens of thousands, but hundreds of thousands of tests. And we'll certainly want to share that with the scientific community as to what we learn. And given that this is obviously a new virus, we're learning things every day in terms of how people react and what happens to people who are contacted, as well as people who have symptoms and test positive.
The initial testing, as we put up there, 1.2% testing positive. What do you make of that?
I actually think that's very encouraging. It means that most of our players and staff did conform to social distancing, wearing masks, and avoiding high-risk situations. I'm actually kind of pleased that it's as low as that. As you know, nationally, the testing positive rate is much higher than that. So I think that we've done a good job educating our players, and the subsequent testing on the surveillance testing has fallen even lower. So, you're seeing teams now having team meetings where players are now enforcing that and getting everybody's buy-in to make sure that they comply not only while they're at the ballpark, but when they're outside the park, and making sure that they take precautions to really give us the best possible chance we can of completing the season. It's going to be a challenge, no doubt about it. This has been a massive undertaking by the Commissioner's Office, the Players Association, all of our medical staffs, and they hopefully are up to the challenge. And I have a lot of confidence in them that they'll be able to carry these protocols out.
Yeah, like in a lot of industries, you know, we're doing our best, right? Trying to get back out there, given there's a lot of uncertainty and things you can't control. One last thing, everybody's kind of in one spot once everyone's arrived, of course. What is the challenge once players and teams are playing games and they're traveling?
Well, I think the commissioner's office has done a good job in trying to reduce travel in terms of scheduling by having regional games, reducing the number of contact points. Because when it comes to this virus, it's all about contact points and the degree of exposure. So we have a very extensive plan for how teams travel, how they eat on the road, how all of the other teams making accommodations for their visiting teams to make sure that they have the same type of hygiene that they would at their home stadium. We also have multiple scenarios for what happens on the road if somebody tests positive, if somebody becomes symptomatic, how we're going to handle that and isolate that. So this will be a big test. We've spent months coming up with protocols, meeting with infectious disease specialists from all over the country to try to come up with the best possible plan. And, we hope we win. But as we've seen with this virus, it takes different turns, and we have to adapt to that. And we're committed to reevaluating this at every step of the way to ensure that we give ourselves the best possible chance of completing our season and protecting the health and safety of the players. One of the things that's been really gratifying is, although there's sometimes, I'm sure there's disagreements between the Players Association and MLB with respect to financial and economic issues, on the issues of safety and health, there's been complete agreement. And we've had a great working relationship with the Players Association with respect to ensuring that the players are safe and healthy. And I think that's the reason for that is that we all share the same goal. We want everybody to be protected. We'd like them to get back to playing, but we want to make sure that everybody's safe.
Well, Dr. Green, we appreciate the information. Again, we've been taking this all in for a matter of months. It's good to hear exactly what is being done. And again, initially sounds encouraging. We hope for the best. Dr. Gary Green. Dr. Green, hopefully we'll talk to you again somewhere down the road. Thank you so much.
Anytime, Brian. Thank you very much.